Hi, I'm Dr. Kimberly Turner, and welcome to Moms, Minds, and Medicine Inside Maternal Health Research. This podcast is your trusted companion on the pregnancy journey, where we break down the latest insights, answer the real questions, and empower you to make informed decisions every step of the way. Welcome to Moms, Minds, and Medicine Inside Maternal Health Research. I'm your host, Dr. Kimberly Turner, a board certified obstetrician and gynecologist. And I'm ecstatic to welcome another board certified obstetrician and gynecologist, Dr. Tamara Means, all the way from North Carolina. Hello, Dr. Means.
Hello, Dr. Turner.
Thank you for coming. So, Dr. Means, I'm not sure if you realize that we're here taping from the historic Morgan State University. And I believe that you have a history here as well.
My father happens to be a professor on the campus of Morgan State. He works in electrical engineering and has been happily training students in the PhD program there for almost 3 decades now. He still has a couple students that he's working through that program, and he is so proud of that institution.
As he should be.
Yes.
So, Morgan is the coordinating center for the Maternal Health Research Collaborative, and just proud to do this work and proud to work amongst giants like your father.
Thank you. I appreciate all the hard work you're doing, and I love the fact that you're educating these women so that they have a more confident sense of what they're doing moving forward.
So, for today, we wanted to give our viewers an overview of what it looks like to have a cesarean section. And this is a very complicated discussion. So, we're going to try to make it as basic as possible. So, first, I just love to give the viewers an idea of where we come from and what led us into this career path. So, give a brief overview of your career path and what you're doing now.
Okay, so finished my residency in Galveston, where I was fortunate enough to have spent time with some of the leaders in obstetric medicine. I came back to Maryland, where I grew up, and joined Johns Hopkins along with Dr. Kimberly Turner, and had the privilege of being there for 11 years. I did get into some leadership in Johns Hopkins, and then moved to North Carolina, where I continued some leadership and continued obstetrics and gynecology. I then went on to get my master's in healthcare administration, and this is where I am now, just outside of Charlotte.
Excellent. And you're still delivering babies, right?
I'm still out there in the middle of the night delivering babies.
Excellent, excellent. So, for those who don't know much about a cesarean, what is it? And give us some of the history of how it came to be a procedure in the United States.
The very brief version of cesarean section is an abdominal delivery through the abdomen and then through the uterus. And then the way you go in, you come back out with a closure of the uterus and a closure of the abdomen.
Yes. All right. Well, how did it evolve in the United States? I bet in 1700 there was no cesarean section.
Well, legend has it that Julius Caesar was delivered by a C-section. However, Julius Caesar was born in 100 BC, so not likely.
Okay.
And then the first actual description of a C-section was about 1500, but it was really kind of morbid because it was a post-death procedure.
Okay.
Our modern maternal survival and fetal survival was really the mid-1800s, and that became more refined in the late 1880s. 1905 is when a gentleman named Pfannenstiel, Dr. Pfannenstiel, created the modern version of the cesarean section that we know now. And with anesthesia and aseptic technique, more and more mothers survived this technique to where we are today.
Right, right. So anesthesia so that women don't feel it. And aseptic means under sterile conditions, the cleanest we can get
Correct,
in
yes.
today's society. Well, first of all, how prevalent are cesarean sections in the United States?
Right now, our C-section rate is somewhere between 30 and 32%. So about 1 in 3 women are undergoing cesarean sections.
Right. So cesarean or vaginal are the two ways a baby can come out of a mother. That seems high. Even I know it hasn't really changed too much over the years that I was in practice. Why do you think it's that high?
It is significantly elevated if you've already had a previous C-section. So 55% of the women who've had a previous C-section go on to have a repeat C-section. And then you have risk factors that put you at risk for having a cesarean section. Obesity, diabetes, increased maternal age at time of their first pregnancy, and then women who have not been pregnant before. All these are risk factors for having a cesarean section. We've put
Mhm.
off having pregnancy until later in life as we get more professional in our careers, right? So these are factors that increase our risk for C-sections.
Right. So if I have any of those risks other than age, is there anything I can do to decrease my chance of having a C-section?
It's an excellent question. If you were to try and decrease your risk, then all of these things that we have talked about increasing your risk, you would want to go ahead and decrease prior to getting pregnant. So you'd want to
Mhm.
optimize your health. You would want to control your weight. And if it's possible before getting pregnant, you would lose weight if that's one of your risk factors. If you do get pregnant when you're obese, really control your weight gain.
Right.
Optimize your health by reducing your risk for diabetes. Okay. And that would be a huge decrease in the risk for C section. It's hard not to have diabetes, but if you end up having diabetes prior to pregnancy or you acquire it in pregnancy, really tight control on that blood glucose to really reduce the risk of having a very large baby that would
Mhm.
indicate a C section because of failure to progress.
Right. So we talked about risk factors. Now let's talk about how do we prepare our patients? If 1 in 3 of the patients that you see in your office are at risk, what do you do to prepare a mother for that type of delivery?
First, we talk about education.
Okay.
It's important to let those mothers know what's involved with a C-section. We want them to ask questions. This is part of their education during their course of pregnancy is education. We optimize our moms with making sure that they reduce anemia risk. So a healthy diet, prenatal vitamins. Okay. Again, we
Right.
talk about obesity and really tight weight gain. We talk again about reducing the risk with tight control of your blood sugars.
Okay.
Also, another risk factor is hypertension, which might necessitate an earlier delivery and inducing labor, which may put you at a slightly higher risk. So, all these factors you may want to control as best you can to put yourself in a situation for success.
And so, just in case somebody hadn't heard the word hypertension, that means high blood pressure. And high blood pressure is not an uncommon thing during pregnancy. And we've had some other episodes about those types of problems. Now, let's talk about the main indications for this 30% C section. What are the top 3 reasons why you might need a cesarean section?
Well, I'm gonna have to go beyond 3 here because
Okay,
it's not just maternal, it's fetal as well. So, for
sure.
maternal reasons, you have labor dystocia.
That's a big word. Hold on. What's a dystocia? How do you spell it?
Oh, so labor dystocia. Labor dystocia means that you have a pregnancy that is, quote, failing to progress. So, it means that you are having a problem moving past a certain dilation and that labor stalls, right? Or that you get to completely dilated and you can't get that baby out. Okay.
Right.
Um, so we talk about uh, labor failures. We talk about fetal position, right? So does that baby sit in the right position, or is that baby head down in the right place? Okay, so
Right.
these are two big factors. And then we
Okay.
talk about fetal heart tracings, okay, and then previous C-sections. I know that goes beyond the three,
Right.
right? And
That's
so
okay.
then
Right.
we have previous C-sections, and then we have multiple. So we go a little bit beyond, and multiple means twins.
Right.
That's a reason for C-sections. So I didn't keep it like short and sweet, but these are things that impact the C-section risk.
Right. And is one more prevalent than the other? What's the most common reason?
So when we talk about indications for first-time C-sections,
Okay.
which which is the thing that dictates subsequent C-sections, it is usually failure to progress in labor or that situation where normal labor does not go as we expect.
Right. So a failure to progress is almost synonymous with that term you use, dystocia, or getting stuck at a certain amount of centimeters, or failing to descend into the pelvis so that the baby can exit the pelvis vaginally.
Right.
Okay. So let's just pretend I'm a patient, and I actually was this patient. Came in spontaneous labor, and all of a sudden the baby's heart rate changed to where the doctor said, I need a C-section. And I'm scared to death, even though I know everything there is to know. What do you do to alleviate the anxiety? And then what are the risks?
Again, we start with education, right? I'm going to tell you what's going on. Fetal heart tracings is a communication to me from the baby. It's
Okay.
telling me I'm not doing well in here, so I need to come out.
Sure.
The way that that baby's communicating might be a series of changes in the heart rate, and it may be something that is sudden in that baby's heart rate. So it's going to
Okay.
tell me what needs to happen. It's going to tell me how fast it needs to happen.
Sure.
So in your case, it may have been quickly or it may have been short. The other things that I need to tell you that may not alleviate your concerns, right? Because it's hard to not alleviate, it's hard to alleviate concerns when we know that there's increased risk, is that you're going to have some risk for blood loss. We prepare for that risk, right? We know what your blood type is, and we know whether or not we're going to have that prepared for you. We're going to be ready for it. We know there's a risk for infection, and we're going to get prepared for that as well. We're going to get you antibiotics before we go back to that OR. We know there's a risk for injury, and it really decreases if we have uh, a team ready and we know where you are in your labor course and we prepare as much as we can. The
Okay.
more experienced, the easier it is, but the further along you are, the risk goes up. And you have to, that's where you educate, right? That's where you
Right.
share what the patient needs to know is everything you can beforehand. And then the reassurance you're going to do the best you can. You do the best you can. You can't take that away.
Right. What do you do if a mother asks for a cesarean before labor?
That's a tough one, right? So there are women that ask for a C-section prior to labor. And believe it or not, the women who are in the profession of delivering babies or in the medical field are the ones more likely to ask for that.
I wonder why that is.
I wonder is
Oh.
maybe we delayed childbearing years and may put ourselves at risk. But when they ask for that, we look at cesarean section rates as one of the markers of our performance. And
Yes.
we counsel them about risk and benefit. We counsel them about the increased risk for infection. We counsel them about the risk of bleeding. We counsel them about the risk for injury to structures around the uterus. Even though those risks are there are some providers that will go ahead and perform that C-section for them. If that's going to be their only pregnancy and that's what they want, there are providers that are more than happy to do that for them.
Right. It just seems like to some people, the labor process is so daunting. And as you for sure know, and I think most of our viewers know, like a normal labor in your first baby can last beyond 24 hours. So if I just have a come in for a cesarean section, how long would that take versus the 24 hours of labor?
That's a very good point. You know, if it's emergent, it's gonna be very fast, but if
Mm.
it's a planned C-section, maybe 30 minutes to 45 minutes beginning to end, you can be awake for it, right?
Right.
Can be a real experience where it's a very freeing experience. It can be a very inclusive experience for your partner. It can be an experience that you don't forget as a positive meeting your child experience. So
Right.
you can understand the positives as well, right?
Right. But it also has a lot of implications if you don't want to have, or if you do want to have more children, excuse me.
Right.
So, what happens on the second pregnancy if the first was a cesarean? Or what could happen?
What could happen? Everybody has a risk for forming scar tissue.
Hmm.
You can't predict who's going to do that unless you've been in that belly before. If you have infection, that risk goes up.
Yes.
Risk for scar tissue means future risk for more bleeding and more injury. So that's a significant risk factor that we're all concerned about. When you've had a previous C-section, it increases the risk for a future C-section if you're not interested in having a future C-section. There's something called uterine rupture.
Mm.
Okay,
That
and
sounds
that
scary.
is an increased risk. Now, when we do trial of labor, the risk is less than 1%, but the 1% that happens to is pretty significant. There's a risk that your listeners probably will never experience, and I hope they never do, but when the placenta attaches to the wall of the uterus, it can be abnormal. And it can be in places it doesn't belong, or it can grow into places like the uterus where it doesn't belong. So this is also a factor that goes along with it. Most of it is bleeding related to a repeat C-section and the scar tissue that you might come across.
Right. Give me a little bit more about what you mean by trial of labor.
So there's two terms that go along with that, right? We call it a VBAC, which means vaginal birth after C-section. And then we do TOLAC.
BAC. Yes.
All right,
Sorry.
VAC, B, VBAC, and TOLAC. So both of them are similar. One is a trial of labor after C-section, and the other is vaginal birth after cesarean section.
Okay.
They're similar. However, a trial of labor after C-section means that you're going to try to have that vaginal birth. Doesn't mean you've had it. And what that means is that hopefully you've gone into labor and that we're going to stand by and support you like you're in labor and you're meant to have this vaginal delivery.
Hmm.
Counseling about expectations and preparation like you're going to have a vaginal delivery, understanding the risks that you might have a C-section. And about 70 to 75% of people actually will have a vaginal delivery. So the chances are good.
Good.
VBAC is when you're successful, a vaginal birth after C-section.
Okay. All right. So 75% of people that want to have a vaginal birth after the first, hopefully, first C section, not more than one,
Right,
are successful, and 25% have a repeat C section.
right.
And you've already talked a little bit about the risk of having multiple C sections. I think the most I ever performed on a patient was eight, 7 prior C sections. So each time that you have another cesarean, as you said, there can be more scar tissue, more chances of the placenta invading almost the scar, and more chances that we can't get the baby out quickly. Anything else that I'm forgetting?
Oh, wow. There are times where you get something called a uterine window, right? And
Ah,
that's an
yes.
area where, not really forget much, but that uterine window where that lower uterine segment, that part where the contracting muscle doesn't exist, starts to thin out so much that there's not much holding that baby in. And that's kind
Mhm.
of worrisome too. Or you mentioned injury. Sometimes that bladder may be the only thing holding that baby in, and it can get damaged when you go
Yes.
in. Yeah.
Right. Yeah, the reason it's a window, like, sometimes we would literally see the baby before we cut the uterus because it almost had separated. And that's just prior to a rupture, which is a much more catastrophic, can cause more bleeding. The placenta can come out. Oh, it's bringing back such memories of being an obstetrician. So, talk a little bit about our teams and our team approach to patients in labor. So, what I recall is that if there's a planned cesarean, there's a team. If there's an urgent or emergent cesarean, there's a team. And it even includes the baby providers or pediatricians. Why do we need all those people and what does that look like?
You're so right about the team. And this team practices and this team works together a lot. So this team is comprised of your OB, and there's going to be somebody who works across the table from your OB. It can be another obstetrician. It
Hmm.
can be a nurse midwife. It can be a trained scrub assistant. It can be a physician's assistant. So that's your operating team. You're going to
Okay.
have a surgical tech that's going to hand you instruments. It's going to help you. He, she will help you keep that field moving and clean. You're going to have a
Right.
circulating nurse. She's going to make sure that everything you need is in that room. She's going to count instruments with your scrub tech. She's going to help communicate between you, your pediatric team, and your anesthesiologist. She's going to make sure everything is going smoothly in that room, and she's going to document what's happening. It's probably clear what that anesthesiologist is going to do, but sometimes it's not. That
Hmm.
anesthesiologist is in charge of making sure the fluids are running in, and that includes pain management through the
Sure.
IV. They may have put an epidural or a spinal, which are two different types of anesthesia that works on blocking the nerves that cause pain. Or you
Okay.
might have to have general anesthesia, but they manage the medications that you'll be getting during surgery. And if you say, hey, I've lost a lot of blood, they may collect blood and send that off while you are in that surgery.
Right.
And then the pediatrician is there to manage that baby when that baby comes out. If that baby's not doing well, they will take care of that in the spot.
Okay. I know that you're not a pediatrician, but do babies that come out by cesarean need any additional monitoring, or is there any other risk if you're born by cesarean versus a vaginal?
Also, a weighted question now, isn't it? So, depends on what they're there for, but even the simple primary C-sections for indication of breech can be complicated. That baby that was in labor and it failed to progress, or you were having trouble with infection, can be at risk. Babies who
Yeah.
came into it with a tracing or a fetal heart monitoring that was worrisome can be at risk. And so they may need resuscitation with help breathing and help with blood pressure. You may have a patient that's a diabetic that needs help with their blood sugars, right?
Mhm.
There may be babies that were breech deliveries and they didn't enjoy it, so they may be a little bit stunned and need some stimulation. So
What's
yes,
a
it can be.
breach?
Oh, breech is when they're facing head up instead of head down like they should be, and you might have to deliver them with their tushy first or some legs.
Right. And they don't like that, I guess.
No, they don't enjoy that.
The babies. Hmm. Yeah, I do want to just emphasize that in a hospital setting, we have a team and we practice. You said that, and I want that to come through loud and clear. So there are no mistakes. Everything is very well choreographed. It's almost like conducting a symphony. And we have drills. We still have drills, right?
Yeah.
And
Yes,
we
we have
practice
drills.
these
Yes,
things.
we do.
Yes. Yes. So again, it's hard to discuss fetal heart rate tracing, but my basic way of explaining it would be we put an instrument on your belly so we can see what the baby's doing during labor. What changes would potentially lead to a C-section in the baby?
We have lots of ways that we can get information back from this baby. What we use is three different terms to help us sort what we think is going on the inside of that uterus and that baby. So we categorize them. We say, this category is completely reassuring, and this baby looks great, and we anticipate a great delivery with a healthy baby, and we're not worried. We have
Okay.
another category that says, we're not so sure. Maybe we'll do some things to make this baby look better, feel better, and keep moving towards the goal of a vaginal
Hmm.
delivery.
Okay.
Then we have another tracing that we say, well, this is very concerning and we need an imminent delivery and we're going to choose cesarean. So we call that category 1, category 2, and category 3, with category 3 necessitating a quicker delivery.
Okay. So we talked about the team that's the hospital team. Let's focus a moment for the team that is the patient's advocate team. What can they do? Because I think the majority of people want to have a vaginal delivery, and the majority of people do. And so many times it's out of our control. What would you want the family to know so that they can help the patient to make the best decision?
The team that's with the mom, sometimes it's family, sometimes it's family and an additional character role called the doula.
Yes.
And so the doula is meant to support that patient. That interaction and the interaction with the family can be really helpful because the patient can be very involved with what's going on with their body and discomfort or fear. When you have that going on, sometimes you don't hear clearly and may not be able to advocate for yourself.
Right.
So they may be able to stop and reintroduce what's going on to the patient, explain it in a way that they're comfortable. They may be able to ask questions that clarify what it is that you're talking about. They may be able to ask questions about the consent that you're going through that the patient maybe wouldn't have thought about. So they're there to communicate and to support. That's really the role of the family. You want what the patient is truly in their favor, that you want that patient to make decisions for themselves. Their family is there to advocate for them and help them make the right decision for themselves.
Okay. Is there ever a situation where the family can't advocate? What I'm thinking is there ever a time when we would force a patient or strongly urge and the family disagreed?
Unfortunately, there are times like that, and the time that I can think of more than any other time is when you have religious situations where a patient may decline any kind of intervention. It may be a time where they do not want us to intervene on behalf of the baby, or they may decline blood products that they would need for survival. These are two very difficult situations where providers want to do as much as they can for a patient or their baby, and they're being denied the access to that care that they want to give. These are situations very hard for the healthcare provider because they want to do as much as they can to
Mhm.
create a really good outcome, and oftentimes they can't. There are times that I've heard of where patients wanna labor without intervention and
Right.
and have been told that, their baby has that third kind of tracing where delivery should be imminent, and they are attached to a different outcome.
Right. And so then there's a third team in that instance, at least there was at Johns Hopkins, where it's kind of a patient advocate team, may involve a lawyer. Is that the case also in North Carolina?
It is difficult, to enact that as it
Mm.
feels like internally as a conflict of interest, but you would go through your, hospital's legal department, and then they would get an order from a judge. It would be in the middle of the night. You'd wake
Oh
somebody up,
boy.
and you would get that order, and yes, it'd be against the patient's will, and yes, I've had to be part of that, and it's not necessarily pleasant. We haven't had to go that far, but there were discussions.
Well, thank goodness that's extremely uncommon. most of the time. We have some minutes or seconds to talk with the family, the advocates, the doula present. I think the last thing I want to bring up with the patient advocacy team is the labor and delivery nurse. Can you talk a little bit about how that person is also your advocate?
This person, that labor and delivery nurse, you're going to spend a lot of time with her. She's going to be the person that's in that room with you and working with you and maybe even examining you in the process of your labor. She's going to be taking care of the medicines that come in. She's going to be communicating with your doctor, and she's going to be supporting you physically and mentally during that process. This is somebody that you want to be working with, and you need to trust her. She's there for you. She wants the same outcome you do. This is your team. This is a big part of your team. And this is where the center of your communication is.
Yeah, nothing beats a good labor and delivery nurse that can communicate well with the patient as well as us as providers.
Yeah.
Which is riskier in the postpartum period? Delivery by vaginal delivery or delivery by cesarean delivery, and why?
Well, we're talking about cesarean sections, so cesarean sections are going to be more risky. And the
Hmm.
risks are going to have to be related to the surgery itself.
Okay.
Risk goes up at least tenfold when the cesarean section was done for infectious reasons and for emergent reasons. So it's not just infection of the wound, but it can be related to sepsis. Sepsis is an
Mm,
infection that is mostly related to a blood infection, but it can be infection that is just full body infection. You
mm,
can have a wound infection. Okay. That can be long lasting. It could be very unpleasant. And anywhere along that wound or that closure can open back up.
mhm,
Okay. So, and you can also have something called hematoma, which is a blood collection that doesn't allow tissue to close or is in
right.
your abdomen. So, the other thing that people may not even think about is post traumatic stress disorder. If it was an unplanned
Yeah,
cesarean section, it happened rather quickly. People can get traumatized by that. It's a very serious thing, and we don't often think about it, but post-traumatic stress disorder and depression, it's legitimate.
right.
Yeah.
What
So
about what about lactation after a cesarean? Is it delayed at all? Breastfeeding?
you can probably nurse, it's probably gonna be about an hour or so, but, we put babies skin to skin, and it depends on how these hospitals run. If you have an opportunity within the post-anesthesia care area, which is something we call a PACU, you can probably do it within about 30 minutes of leaving that OR, so maybe a delay about 20 minutes, 30 minutes from delivery. Baby's sick and it goes to the NICU, is gonna be delayed, and there's a small increased risk for NICU, neonatal ICU, uh, deliveries, and so that will be a significant delay, and, those are babies that have a bit of a struggle after delivery.
Right. Does my milk come in the same way after cesarean as it does after vaginal?
It does. It does
Good.
come in the same. Sure does.
Alrighty. So anything else that you want to tell our viewers or any take-home points?
I think that one of the most important things that our patients needs to know is that we are advocating for what our patients want, that none of us go into a labor and delivery wanting to just have a C-section so that we can go home. I think
Mhm.
that there's a misconception that we're not there to work or don't feel invested in our patient's outcome. There are so many more risks involved with shortcuts that it is not only not worth our time to do that, but we're also extremely invested in our patients. We went into this business because we care about every stage of our patients' lives. We help them make good decisions for themselves. We work with them at such an important part of their lives, and then we take care of them as they get older and support them there too. So it's very important. And just as you've taken care of women from adolescence into their menopause years. So it's a
Right.
lifelong relationship. we're invested.
Right. Yes. So thank you. Thank you. I cannot believe we went through kind of the ABCs of a cesarean in roughly 30 minutes. So we just want to thank you again for joining us. And thank you to the viewers for viewing. And we hope to have you back on a future episode.
Again, I'm so honored to have been with you, Dr. Turner. It is an honor to have worked with you in the past as well.
Same. Same.